already. Hopefully you guys can see me. If not, the EKGs is what's more important.
There's a step stool in my closet.
It's okay. I thought about that, but then I'm like, what if I'm walking and I fall off of it? So no, thank you though. So let's see. Okay. So my name is Flor. I'm one of the PGY1s. Today I'll be presenting on Syncope EKGs. They're part of the EKG and Visual Diagnoses series. I want to give a special thanks to Dr. Tang, Dr. Gopal, and the rest of the EKG, RADS, and Farm team. So syncope is a transient loss of consciousness due to disruption of blood flow to the brain. And it also has the inability to maintain postural tone. There's various etiologies. There's cardiac, neurologic, vasovagal, orthostatic, or medication related, but I'll be focusing on cardiac syncope as it doubles the risk for death. And an important part of the workup are EKGs as they're simple, non-invasive, and useful for risk stratification. When thinking about cardiac syncope, we can think of causes that are structural, arrhythmias, or cardiopulmonary, but even within those categories, the differentials are very broad. So it's good to use an algorithm to systematically read EKGs in the setting of syncope. So we can use the Hart's algorithm, looking at the heart rate or rhythm, whether it's tachycardic, bradycardic, or normal sinus rhythm. Looking at the electrical conduction, the PR interval, the QRS, if the PR intervals short, if the QRS is wide, we think of Wolff Parkinson White, looking for long QT syndrome, looking at the axis, the R wave size and progression. If it appears earlier, we think of WPW. If there's tension or hypertrophy, we can think of aortic stenosis in the elderly and hypertrophic cardiomyopathy in the young. Then we also look at the ST and T wave changes for ischemia or Arvd, which is arrhythmogenic right ventricular dysplasia, and Brugada, which I'll get into as well. So we'll start with a case of a 20-year-old female coming in with palpitations and syncope, and we'll interpret the EKG together. So can someone tell me the heart rate or rhythm, whether it's tachycardic, brady, or normal sinus rhythm? You don't have to give me the specific number, just tachy, brady, normal sinus rhythm. Yeah, so normal sinus rhythm. And then let's look at the electrical conduction, the PR, the QRS, and the QT. Anyone see anything abnormal? What about the PR? Yep. So if we look at the PR, it's a short PR interval, it's less than 120 milliseconds, and we see the early slurred upstroke of the QRS, known as a delta wave in the precordial leads. And looking at 1 and ABF, the axis is normal as their leads are both upright. The R wave, there's an early progression as a QRS occurs earlier. There's no tension or hypertrophy. And then for the ST and T wave changes, there's some mild ST depression if you look in the anterior leads V1 through V4, and discordant just means that the depression occurs in the opposite direction that the delta wave that the QRS is pointing. So all in all, the diagnosis is short PR, wide QRS that you can also see. Syncope, it's Wolff Parkinson White. So other EKG findings can be the wide QRS, tall R waves, a dominant S in V1, and T wave inversions. So Wolff Parkinson White is a pre-excitation syndrome. We have the regular pathway of going from the SA node to the atria to the AV node and the ventricles, but then we also have an accessory pathway. And there's 3 different types of WPW. There's type A and B and C. Type A and C, you'll see tall R waves in V1, and you'll distinguish between them based on the axis. And that occurs with left-sided accessory pathways of the heart, versus if it's a type B, you'll see a deep S wave in V1, and that occurs when the accessory pathway is on the right side of the heart. Then we can also look at re-entry circuits that can be caused by WPW. orthodromic means that it follows the normal route of going down the SA node and then down to the ventricles and then going up the accessory pathway. That EKG will show a normal QRS, no delta wave, and you can see a retrograde P wave after the QRS. The other circuit is antidromic. So for that, it'll be in the opposite direction. You'll go first down the accessory pathway and then up the ventricles, up the AV node, atria, then back down to the ventricles. For that one, you'll see a wide QRS, the delta wave, and rarely see P waves. And here, the delta wave, delta airlines, you can see the upstroke as they're taking off, and you can see also T wave inversions. And this WPW syndrome can predispose to cardiogenic shock, SVT, BFib, and AFib. The second case we have is a 25-year-old male coming in with exertional syncope. Again, what's the heart rate or rhythm? Tachybrady or normal sinus? Yeah, so it's tachy or normal sinus rhythm. It's in the cusp of like the 100 rate, 101 or 2. So yeah, it's tachy. What about the electrical conduction, the PR, QRS, and QT? That's normal. And the axis is normal if you look at the leads 1, ABF, both pointing upright. Now, what about the R wave? Do they seem small or big? Yeah, so it's big, so we can think of large voltages. And also, if you look at the inferior leads, you can see inferior and lateral leads, you'll see narrow Q waves that are described as dagger-like. So for the left ventricular hypertrophy, if we look at the criteria for LVH, Skov-Lion criteria, the S wave depth in V1 plus the highest R wave in B5 and B6 must be greater than 35 millimeters. And if we count out each box of 5 millimeters, it is definitely more than 35. So it fits the criteria for LVH. And then the Q waves that you see in the inferior and lateral leads are pathologic if they're greater than 40 milliseconds, if they're greater than 2 millimeters deep, if they're greater than 1/4 the depth of the QRS, or if they're seen in V1 to V3. And there's no ST or T wave changes. So young man, exertional changes, syncope, coming with Q waves and left ventricular hypertrophy. So it tells us there's hypertrophic cardiomyopathy, yes. So this occurs because there's mutations in the sarcomere protein genes that causes asymmetrical hypertrophy in the interverticular septum, and it predisposes to ventricular arrhythmias. The way I like to think about this and the EKG findings is using an analogy of an athlete who's muscular and breaks your heart. So this happens in athletes, they're young, they're muscular, so that represents the left ventricular hypertrophy. And then the Q waves are described as dagger-like. So this football player is holding this sword or dagger-like that's in the shape of like a Q wave that you can see here. So you can think of that when doing pattern recognition for this disease. Third case, we have a 20-year-old male who's ill appearing. You get this EKG, and right after they collapse. What's the heart rate? Yep, normal sinus. And then what about the electrical conduction? What about the PR, QRS, or QT? Let's look here. Close, so there's widening of the QRS. Specifically, you can see it in V1 and V2. It's wide, greater than 120 milliseconds. And then you'll see also the RS, R prime in V1 and the slurred upstroke of V6 of the S wave. And then the axis looking at leads 1 and ABF both pointing up is normal. The R wave is normal. There is no tension. And then since we're looking at the QRS part that's widened, and then the ST segment. Does this look like a regular ST or does it look a little funny? Yeah, so if you look at that specifically, this is described as a coved ST elevation that you see in V1 and V2. And the diagnosis for this is Brugada. So if you see a young person who has syncope, has the wide QRS with a right bundle branch block, and a coved ST elevation, you can think of Brugada, which is due to mutation in the cardiac sodium channel gene. For this, I use the analogy of a horse in a shed. So this is like a dome-like structure where the horse can be stored or kept, and that's type 1 Brugada. Type 2 is defined or called the saddleback ST elevation. So again, the analogy of a horse using the saddle. And then type 3 is a combination of type 1 and type 2 morphology. For this diagnosis, you have to have these findings and the EKG with a right bundle branch block, but also a clinical symptom of documented VTAC, VFib, family history of families having their EKGs with coved ST elevations, or a sudden cardiac death in the family when they're less than 45 years old, syncope or nocturnal agonal respirations. And the complication of this is that it can lead to sudden unexpected cardiac arrest in people with structurally normal hearts. 2 more cases. So case 4, we have a 20-year-old female. She's outside in the heat, becomes lightheaded and syncopizes. So here, the heart rate and rhythm are normal. What about the, sorry, well, we saw that already. So what about the QT? Yeah, it's long. So this one, if you calculate, it's around 580 milliseconds. And then looking at the axis, 1 and ABF both pointing up, it's normal. The R wave is also normal, and there's no hypertrophy or tension, and there's no ST or T wave changes. So diagnosis, long QT syndrome. And when you're measuring the long QT, you look at the lead that has the longest QT interval, or you can look at leads 2, B5, or B6. And if there's a U wave that's right next to it nearby, or a large U wave greater than 1 millimeter, you'll include that in the measurement. But if it's smaller than 1 millimeter and further apart, then you won't include that in the measurement. And again, commonly we see long QT syndrome with electrolyte disturbances like hypokalemia, hypomag, hypocalcemia, hypothermia, MIs, tricyclic antidepressants, SSRIs. It can be corrected for a heart rate using a formula. And if it's greater than 440 milliseconds in men, that's prolonged. And if it's greater than 460 milliseconds, that's prolonged in women. And then if it's greater than 500, that increases the risk for torsades. And this case that I found particularly was interesting because this patient who got this EKG was sent home because it didn't look right out as a long QT. But then when the second person was looking and documenting the EKG, they actually counted it out and it was long, and they had to bring them back in to find the cause for it. And the last case is a 15-year-old male who's playing basketball and suddenly collapses. So here the heart rate and rhythm is normal sinus. What about the electrical conduction, the PR, QRS, and QT? What about in V1 and V2? So the QRS is wide. If you look here, the QRS is all wide. And it doesn't have the right bundle branch block, if you look here, or in V6 for the upslope of the S. And if you look at the axis, if you look at lead 1 pointing down and ABF pointing up, it's a right axis deviation. Then the R wave is normal and there's no tension. And since we said that the QRS is wide, there's also something that you can see in V1 and V2 if anyone can tell me or notice. It's a little hard to see in this one, but I'll just give you the hint that it's in V1. So specifically looking here, I'll have a better picture in the next slide, but there's this little blip or wiggle that's known as the epsilon wave. And you can also see T wave inversions in leads 2, 3ABF, and also the precordial leads. So the epsilon wave is specific for the arrhythmogenic right ventricular dysplasia. And other EKG findings are prolonged S waves, upstrokes of 55 milliseconds in V1 to V3. So this long name, arrhythmogenic right ventricular dysplasia, ARVD, is just when the myocytes in the right ventricle are replaced with fat. So you can think of it as myocytes in a sea of fat. So the conduction won't be as smooth. It has to get through all that fat. So that's why the conduction will be delayed. And you will see a little blip, a little wiggle, like the Wiggles and the dance that they do. So it's kind of a reminder of what the shape will be like when you look here. I was surprised to find that it fit pretty well. And then you can also see the prolonged S wave upstroke in V1 to V3. And this can cause sudden cardiac death in young individuals as well. It's the second most common cause of that, apart from hypertrophic cardiomyopathy. And that's it. So the take-home points of this is there is a systematic way to read EKGs in the setting of syncope. You can look at specifically using the heart mnemonic. There's more differentials under the heart rate and rhythm, the axis, the R wave, but we would be here for a longer time. So I was just focusing on the electrical conduction. If you see a PR interval that's short, wide QRS with a delta wave, think of WPW. Look for long QT syndromes. If there's tension or hypertrophy, remember the athlete who's muscular, young, muscular for the left ventricular hypertrophy, breaking your heart, the Q waves with the dagger-like appearance, think of hypertrophic cardiomyopathy. And then for the ST and T wave changes, you can think of the horse analogy where they're kept in that coved shed. And the second type is the saddleback shape, ST elevation, so you think of Brugada, and then the epsilon wave when you think about the Wiggles. So you see the little blip around the QRS and after the QRS in the ST segment, and a prolonged S wave in V1 to V3, then you think of ARVD. And those are my references. Any questions?